not me, of course, because I was dancing. So we will have an exciting 1.5 hours for this morning. I am Virpi Honkala from Finland, and my co-chair here is Dr. Chin Lon-Lin, who is the president of Taiwan Society of HPH. So we can probably call him the father of Taiwanese HPH. And we have a very important theme for this morning. What capacities do health-promoting hospitals and health services need to improve their contributions? And we have 3 real experts to give us a talk this morning. And I can see that our mother of international HPH, I know all the titles of Dr. Shuti Shu, and I'm not going to repeat them because she's whatever, but she is the mother of this conference, the inspiring spirit of health-promoting hospitals and health services all over the world. And I will give her the first talk on how can health policy and health system capacities for health-promoting healthcare be created and maintained. Shuti, please.
Thank you, Virpi, and good morning, everybody. It is our pleasure and honor to speak on how can health policy and health system capacities for health-promoting healthcare be created and maintained. Because at the beginning of Taiwan's network, I was sort of the pioneer of it. We established the network, and now I'm in the government to have policy support for it. So I will try to talk a little bit about our thinking of how to communicate with policymakers and how do we create more policies to support it. So the first part, I will introduce the background. I will propose the diffusion of innovation model as a framework of our work. And next, I will use cancer screening as an example to visualize how can we create policy to support health-promoting healthcare, and at the same time, how can health-promoting healthcare support the implementation of policy. And the third part, I will talk about the overall picture of our current policy support for health-promoting healthcare. So this is the diffusion of innovation model proposed by Rogers E.M. And the definition he gave in 1962 is that diffusion is the process by which an innovation is communicated through certain channels over time among the members of a social system. So in his theory, the first part is an innovation. However, here I try to draw a picture that what is in my mind about diffusion of innovation. To me, first of all, I will look at the needs or problems. And we have the innovation at hand, which is HPH. So we try to see how is this innovation gonna help solve people's problems or needs, okay? So if we can articulate clearly that how are we going to meet the needs or solve the problems, then hopefully there will be very good diffusion. Or we advocate for the existence of the needs or problems, and we advocate for the possibility of our innovation to solve it. We create the demand, and also there's a higher chance of adoption of the innovation. And by adoption and implementation, hopefully there will be outcome, value, or utility. So HPH as an innovation, there are two components of an innovation. One component is the hardware, consisting of the tool. For example, the HPH standards and the self-assessment tool. The second part is the software, which is the knowledge base for the tool. So this is about the concept, the definition, and evidences of HPH. And as I said, if we want to have better diffusion and adoption, then very important that we have to be aware of the needs and what does the government care, for example. So, for example, the currently government everywhere, they care about population aging, they care about economic downturn, they care about climate change issue, and they care about public expectation. And we need to tell people that HPH can lead to lower cost, better health outcome, more environment, co-benefit, and higher public satisfaction. And regarding the frontline people, what do the HS managers care? For example, they may care about internal missions required by their owners or donors. For example, there may be some external missions or requirements they have to meet. For example, the regulation, the policy trend, the accreditation requirement. And perhaps they care about more profit. So what is the payment for it? And perhaps they care about higher patient satisfaction, better image and marketing, better human resource management. And perhaps they care about higher or same quality at lower cost. So, for example, we can talk about whether HPH can do better resource management. And I think, to me, the very important thing is that we care about the value of us as a profession or as a healthcare organization. So, we can look at the relative advantage of it, which is the gap between benefits and cost, and the competition between innovations. So, what do government or healthcare managers care about? They care about the cost. For example, the cost in terms of money, the cost in terms of time and personnel, facilities, skills or complexity of this innovation. And they also care about the cost in terms of uncertainty or failure, etc. We need to make HPH cheap and simple and easy, okay? And then we need to communicate with the potential adopters in their social system. And quite often, we need to engage opinion leaders and change agents, and to have the early adopters as champions or success stories, okay? So, there is a policy journey. First, diffusion, to demonstrate the needs for it, to demonstrate the effectiveness and cost-effectiveness of it, to demonstrate the know-how of it, okay? And then the adoption, create the policy, okay? And if we successfully make the government adopt it, and then we have to implement it. So here comes the phase of implementation. And that's about the partnership between government and the healthcare providers. So then the government and the healthcare managers allocate resources to do it, to build capacity to do it by learning, recognition, and dissemination. And then if there is very good evaluation which shows success of it, and also we have some reward for it, and if we can build credibility of it, then hopefully there will be sustainability. So we can have the journey of diffusion, adoption, implementation, and sustainability. Okay, so I'm going to visualize this with an example of cancer screening in Taiwan. Here we demonstrate the needs that Taiwan has one of the highest mortality rate and incidence rate of cancer as compared to the other countries. And cancer has been the number one killer since 1982, which accounts for 28% of our annual deaths and 10% of the national health insurance expenditure. And we have the past experience of success through the implementation of pap smear screening. Here, the blue bars are the screening rates. With the higher and higher screening rates, we successfully reduced the mortality by 60%. So the policymaker, they can have confidence in it, right? And we also, show that there's an international trend, there's the advocacy by WHO that 4 kinds of cancer screenings are suggested: breast cancer, cervical cancer, colorectal cancer, and oral cancer screening. But at that time, we only have universal coverage for pap smear, so we advocate to expand the coverage for the other 3 types of cancer screening. And we also calculated the expected benefits and potential cost for these 4 types of cancer screening. And we found that for most of them, it is cost-saving or it is cost-effective. And we also showed that there are evidences regarding the implementation strategies. So it's possible to do it. For example, we have strategies to increase the demand, to improve accessibility, to improve delivery. This is the review done by US CDC. And all these strategies are included actually in our HPH model. Okay, so we can apply HPH model to improve the implementation of cancer screening. So we have the needs and we have the weapon to solve it. Okay, so then we get the political commitment and the buy-in by the politicians. In our president's first campaign, he declared to reduce cancer mortality by 10%. And then here came the National Plan on Cancer Control, which aimed to achieve 10% reduction by the year 2015. Okay, so short term we need to, of course, increase the volume and quality of cancer screening and the quality of healthcare. So the first step is to expand cancer screening and to achieve high coverage of screening. Okay, so we then get the funding for cancer screening program. The extra funding is through the raise in tobacco tax. Okay, 6% of it is allocated to cancer screening, and then we set the goal for cancer screening, which is very high to achieve. So it's very challenging. Just within 1 year, we need to have a 1.44 increase in volume. So now the government has the urgency to find a very good partner to do it. So the new National Cancer Screening Program includes everything, but also they see the importance of the delivery system. Okay, and actually in Taiwan, hospitals can reach 60 to 70% of the target population for cancer screening. So in addition to working with the clinics, we also try to improve the capacity of hospitals in cancer screening. Okay, so here are the policies to support delivery redesign. We have the project-based subsidy for hospitals. They have to implement with this subsidy for extra personnel, new IT function for automatic assessment and reminding and tracking of results. And they need to do patient education and outreach community services with this subsidy, and also to have good self-monitoring and analysis of their performance. And then we also have this training for the personnel. We also have external audit monitoring, and we do the feedback to every hospital, and we do the public reporting of hospital performance. And also we have, in addition to fee for screening, we also have extra payment for good performance. So we have fee for service, we also have pay for performance for cancer screening. And actually we got very high participation rate by hospital, which covered 92% of outpatient volume in all hospital services. And this is the training for personnel, this is the IT system, This is the information and education for patients and visitors. This is the outreach services in communities. And we also look at the adoption of these effective strategies we recommended, and the adoption rate of strategies are high. And also we have growth in the facility for cancer screening, and we have the mass media promotion for good practices, and we also have the social mobilization to increase the public demand for screening to help hospitals do a better job. And then we found that actually between 2009 and 2010, for mammography, for colorectal cancer screening, for oral mucosa for oral cancer screening, for pap smear, there's successful increase in the screening volume, and the purple color indicates the screening volume done by the subsidized hospitals, and you can see actually the growth in the volume appeared in the subsidized hospital. So this strategy, this subsidy is effective. And by such increase in cancer screening volume, we also, of course, have increased a number of detected cancers and precancerous lesions, which are very remarkable. Okay, I'm not going to do this. I just taking you through the journey, okay, of it. And so we successfully achieved our national goal for screening volume, for increase in screening volume, and actually by the participation of every kind of hospitals, we achieved very good equity in screening volume, in screening rate between communities of different levels of resources. Okay, this is actually breakdown. That actually is the communities with in the rural areas. But actually, they have very high screening rate. Okay, and also we have quality control of the program, and also we did some analysis which showed that being an HPH is also one important success factor among those hospitals participated. Those which are HPH, they did even better than the others. And then we tell our public that a patient came for eye problem and eventually found to have a fatal cancer and got his life saved. This is what we do in HPH. This is what HPH is. So we also do the promotion of this idea to the public. Okay? So we can turn problem into opportunity. Whenever there is a problem, there is an opportunity. Whenever there is a need, place in HPH, okay? And there is no possibility to have no problem. If you don't see any problem in your country, try to find out where the problem is. Okay? You can do it by needs assessment or by looking into the media and see what people are discussing there. So for example, we can place in HPH, we can make HPH a strong partner for environment-friendly issues. Okay? And also we have HPH joining in various issues. Even for the DOH, our Ministry of Health, they owned more than 28 hospitals, and for the hospital reform, we advocate for health promotion in healthcare by public hospitals. And when our national health insurance was undergoing their reform, again, there is a capitation payment, and then we have our pioneers, our HPH pioneers, to get the project for capitation payment, and now they are doing quite well. Okay. So finally, for the policy support for health promoting healthcare, in Taiwan, the National Health Insurance pays for acute and chronic illness care, but it's the Bureau of Health Promotion to pay for the preventive services, including the checkup for different age groups and the cancer screening, smoking cessation, and preventive dental services. Okay, and the Bureau of Health Promotion provides budget support for health promoting health care in two ways. One is through payment, the other is through project-based grant. So, for example, for payment, as you have seen, we have the fee for preventive services. Now we are developing the fee for health education. So very soon, probably June or July, we will have payment for health education. That is not only for doctors. Actually, nurses, dietitians, health educators can get the payment for health education. And we are developing others. For example, for pregnant women, the holistic health promotion, we are trying to pay for that. Okay, and for children, prevention of injury, we are trying to develop payment for education to prevent injury of children. And also here, as you have seen, we have paid for performance. We already have paid for good performance in cancer screening. And now with the new scheme for smoking cessation payment, we also included payment for good performance in smoking cessation for providers who achieved higher success rate or who have the lower cost for each unit of success cessation. Okay? And as I said, the NHI has 8 hospitals as pilots for capitation-based payment. Okay, and we also have project-based grant for hospitals. Since last year, we have the HPH grant. We encourage hospitals to do projects and show their excellence in staff health promotion, or obesity prevention and control, or age-friendly healthcare, or environmentally friendly healthcare. And then we also already have the grant for smoke-free hospitals, and we are developing the grant for baby-friendly hospital and clinics. Also, and there are other policy support. For example, we include health promotion indicators in our national core measurements for healthcare quality to be monitored and improved. And also, we support to include health promotion in accreditation standards. And we also try to participate in international recognition pilot project. So in conclusion, with the support from the network and government policy, hospitals in Taiwan welcome the HPH model. We now have 76 members, and they found it helpful in improving quality of patient care and meeting accreditation requirements. And hospitals have demonstrated themselves to be a powerful partner for the government in supporting the implementation of HP policies and promoting population health. So, to create policy support, and actually I think the key to success is we, us, you, together, we as the change agent, and we as the leader, and we believe in health promotion. We have the evidence, we hold the love for it, we collaborate, and we be devoted, and then we will make it. Thank you for your attention.
Thank you so much for this very inspiring and most interesting talk. If there are any questions or comments, there are 2 microphones on both aisles, and I ask you to go to the microphone. We could have 1 or 2 questions now, or then we might have some time after all the presentations to have the questions, and in that case you can kind of find your way to the microphones and be ready there. I don't see any movement right now. Thank you so much, Shruti. This was really, really most outstanding presentation, and we will move on. Professor Jürgen Pelikan, who also, you know, I'm sure you know him so well already, but he is the father of HPH science to me, being director of WHO Collaborating Center for Health Promotion in Hospitals and Healthcare. He comes from Vienna, Austria, and he is the chair of a scientific committee, and he's actually in charge of the scientific program in this conference. So Jürgen Pelikan will speak about what organizational capacities do make a difference for the implementation of HPH. Please, Jürgen.
Thank you so much, Virpi. Good morning, everybody. It's a real pleasure to talk about what organizational capacities do make a difference for the implementation of health promotion in HPH hospitals. And using data for that, many of you have supported us to collect, and many of you have put into our questionnaire. Well, what will I do in this short time? I will make a short introduction, then I will say a little bit about the PRICES project. I will try to talk about 3 questions. I will give a summary of results and have some conclusions. First, for introduction, you see, the question we first have to answer, if we are talking about capacities for implementing, the question is implementing what? And here I have put for you a definition of our mission, which is based on further documents, on the Budapest Declaration and the Vienna recommendations, and which is part of our network. And what does it say? A health promoting hospital and health service is understood as an organization that aims to improve health gain. And I think that is the real important difference we make. We are talking about health gain as a positive concept, of positive health. Of course, that does include clinical outcome, but it's much more than clinical outcome. It's quality of life, it's health literacy, it's satisfaction of people. And therefore, because we have this radical change in paradigm here, we are looking not just at patients, but we are looking at staff and community as well. And since hospitals are organizations, when we want to follow this very comprehensive approach, to do that, for these kind of stakeholders, we have to look at processes, cultures, decisions, and processes of this kind of organization. And you see that we take these 3 groups of stakeholders seriously, and especially what you see here, we try to focus on the needs of vulnerable groups and on the environment. Everybody who has been to the 3rd plenary yesterday has seen how seriously we take these groups. Well, on the other hand, if we are looking for capacities in HPH, we have to look at hospitals, and hospitals are very specific kind of organizations. Mintzberg, an organizational expert from Canada, has said that hospitals are professional bureaucracies. And what does that mean? They are bureaucracies in one way, so they can use standardization and control, but at the other end, they are professional organizations, and professionals are autonomous, and they are looking much more to their peers partly than to their management. And therefore, if you want to change professionals and get them, you have to invest in education and training of professionals and not just in management structures of your hospitals. Hospitals are people processing services, as Hasenfeld has said. What does that mean? If our services are changing people, then we have to involve the people, and it's about co-production, and as health promotion would say, it's very much about empowerment and participation of clients. Of course, these services are risky, therefore risk control and safety is a primary issue. There are knowledge-based services, therefore evidence-based is important, and quality management. And as we have heard so many times, and just again from Shuti, they are costly services, therefore cost effectiveness and financial cost containment are very important on the agenda, and we have to take that into account if we want to help or support hospitals to do more health promotion. Concerning evidence and quality, of course, we had very important lectures concerning that in our 2nd plenary. Well, what is the message here? Medical practice is becoming more a science and an art, but of course many would say it shouldn't lose to be an art as well. Therefore, it's about clinical intervention should be, as far as possible, be based on best available scientific evidence, but this evidence cannot be produced directly by hospitals. That's a question of research. We need studies, we need reviews, we need standards, we need guidelines. On the other hand, it's about quality, and quality is about the organizational production of these services, and therefore we were looking at quality philosophy, and we are orienting ourselves at an obedience. We know that if you want to improve quality of outcomes, you have to improve quality of processes, and to do that, you have to improve quality of structures. And quality is something which you cannot do just once. It's a circle. You always have to start again, plan, do, check, act, and start again. And it's very much about quality management, and quality management has to be introduced in a hospital, and we will see with our results that hospitals who have good quality management do better concerning health promotion as well. Well, consequences for HPH are that there's the expectation that our health promoting interventions have to be evidence-based as well, and we were linking our endeavor to quality. Capacity is an important word today in this. You see, the concept of capacity building comes from developmental aid, where they found out if you want to help countries to develop, you can't just do projects or give money to them. What you really have to do, you have to build capacities. And what does it say here? You have to build capacities on 3 levels. On the level of the individuals, knowledge, skills, commitment, resources. On the level of the organizations, commitment, culture, structures, and resources. And on the level, and Shruti was just speaking about that, on the level of the environment, where it's about political will, supportive organizations, ideas, and other resources, and you have to change public opinion as well. In our network, we have tried to make the very open and interesting paradigmatic concept of HPH a little bit more practical. We have done that by developing 18 strategies. We have developed strategies which take healthcare as it is already done in hospitals and try to improve the health promotion quality of the existing services. And on the other hand, when we want to do health promoting hospitals, we have to add to hospitals preventive and promotive services. And I show that because we have had used this model when we operationalized our indicators, how to measure activities in hospitals. So it's about empowering people who are working in the hospital and people who are living there, empowering people who are working there. It's important not just to empower people, but you have to change settings to make settings, as we heard yesterday, where the healthy choice is the easy choice. And of course, we think these other 3 kinds of strategies can be done by and have to be done by every hospital. But the other ones, where it's about preventive services and promotive services, or even using the capacity of the hospital to change the community in a more health-promoting direction. Of course, you need a mandate for that, you need resources for that, and therefore I think most countries will envy Taiwan, where Taiwan is giving real support that hospitals can do these 3 kinds of strategies. To do that, we are using the Dolobedian model, that is, we need to look at structures, processes, and outcomes, and we have to define them, we have to assess them, and we have to develop them. And to do that, we have to become more concrete, and you see, all of you know the standards which help us to do this kind of quality work. Now I come to the empirical questions and to the findings from our study. We have to have developed a model for that. That's the PRICE's HPH evaluation model, which is published in the first number of Clinical Health Promotion. You see, here we start again. The outcome is improved health gain for patients, staff, and community. In our project, we could not measure that, but the new project, the recognition project, which WHOCC in Copenhagen is doing, will do that. But I think that's not such a great problem, because most of the strategies which are here, that are the 6 kinds of strategies, there is enough evidence already that measures of these strategies have an effect on improving health. Then we have to look at hospital structures, and that will be one of the questions I will try to answer. In how far do structures, capacities which have been built up here in hospitals, in how far do they make a difference concerning the implementation of these measures and strategies? And of course, WHO was wise enough not just to produce a concept, but to start networks. And networks are new collective actors which have agency and which can do something. They can do something to help to support hospitals directly, and here you see the strategies, how they can do it, but at the same time, networks, and they can do much better than single hospitals, as a collective actor, can try to change their environment, their political environment, in the right direction, so they get more support they need for doing what they want to do. Yeah, we did 2 surveys on that, one on the networks, one on the hospital levels. I will use data of both of these. Here, the most important data, what you really, I think, have to know is that in the end, 28 networks were participating. And of these networks had 529 member hospitals, and the response rate was 80% for the networks, it was 34% for the hospitals, and in our analysis we are using 159 of these 180 hospitals which fulfill the criterion to be a real acute hospital, and they are from 25 networks. First research question, what organizational HPH capacity structure supports the implementation of health promotion activities in hospitals? Here we have our independent variable. In our questionnaire there were 17 report questions concerning these fields, concerning hospital coordinator, personnel structure, policy standards, financial resources, quality assessment, outcome monitoring and cooperation for HPH. With other partners. That's the independent variable. The dependent variable are activities of hospitals. We have developed 105 items or indicators to measure these 18 strategies. We are using here of these a selected number of 67 items, and we have put them together, so we have 8 dimensions and 27 items for indicators concerning patients. Here it's the same for staff, and here's the same indicators for community orientation. And what we are looking at is, if hospitals have these structures, does it make a difference for implementing these activities? Before we do that, it's good to see how far our hospitals, our HPH hospitals, implementing. And you see on a scale from 0 to 10, the mean is 6.87 for patient-oriented, 5.93 for staff-oriented, 6.06 for community-oriented for the whole sample. And you see there's something more done in concerning patient and less concerning staff and community. But the interesting thing here for many of you is, if we look at the 19 hospitals who took part from Taiwan, in every dimension they have better results. And they are much nearer to fulfilling it. Of course, we see we are not so bad concerning this, but there are still potentials to reach a higher value. Now we can look at differences. And you see 100% in Taiwan have that. Yeah? So you see again, the Taiwanese HPH hospitals are doing the right thing, yeah? And therefore they are more successful. That's for patient-oriented strategies. I go further. The same you have for staff-oriented strategies. You see here the interesting thing is these strategies are, these capacities are a little bit more successful for staff. on average 13%. And here again you see monitoring of HPH indicators is one of the, that is even higher. Written HPH policies again is a very important means which makes a difference of 21%. Third, we can look at community. Community is a little bit lower than was staff. Again, you have here a very, again, written HPH policy strategies makes the highest difference. And again, you see in Taiwan 100%, in the other hospitals only a little bit more than half. So there you have, or here you have a real potential specific financial sources for HPH, and we just saw that the Taiwanese Bureau is giving these resources. That really makes a difference. If we try to, you see the next question is, we could show that every of these structures makes a significant difference. Yeah? The question now is it complementary or additive? And you see it is additive. On average, the more capacities a hospital has, the better its average value. Yeah? So therefore, you see 32% of the variance are explained together by these 7 capacities we could measure. So it's good to use these capacities, to implement them. Of course, if you have to make a choice, better choose the one which are more effective. But you see, the best thing is if you combine these strategies and invest in all of them. So to put that together again, you see, and that, of course, it's interesting that the highest effect is for staff, but maybe for staff, health promoting hospitals makes the biggest difference, because for patients, so many other movements are already doing something. For staff, it's the highest, followed by community and then for patients. But you see, for every of these dimensions, there is a strong effect which could be proven, and all these effects are significant. Yeah, just to put that together, to look a little bit more clearly, what kind of capacities do you have to build? You see, you need an HPH coordinator who is responsible for planning, coordinating, and evaluating. It's good that you have, besides the coordinator, an HPH unit or a team or a steering committee or a working group. You need this kind of social structures. It's very good to have written policies, many written policies for specific issues and activities. It's good to have a minimum of at least one specific financial source for HPH, be it an international HPH, internal budget or funding by government or by health insurances. It's good to use make quality assessment either by the 5 HPH standards or by, like the Swedes are doing it, with national indicators or standards. It's important to monitor. Here you have things you could monitor, and it's important to form an alliance outside with other groups like patient organizations or research centers or staff unions and research centers. All that makes a difference. Now, since we could show it makes a difference if a HPH hospital builds internal capacities or not for its activities, now we wanted to look how can networks support this kind of thing. And we were looking at 2 strategies of networks, supporting organizational development of hospitals and supporting personal development. And here we were looking at implementation tools and specific task forces. And here at written HP policies again and HP assessment, and that would be a membership criterion. And again, you see, and you see here, the difference is in the number of the 7 capacities hospitals have. So we can show if a network, for example, demands of its members written HPH policies, and you see 11 networks do that, then it's 12% or 13% more activities you can find, or we can find, in the hospitals, and that all these are very significant again. And there is another thing here concerning personnel, to have regular network conferences, and 19 networks have that, is important. It makes a difference too, because that is a very important means of sharing information, of motivating people, of using common knowledge. Again, we can look at that in this way. Does it make a difference if a network has more of these strategies? Yes, it does. 20% of the variation is explained by that. Of course, you see there is variation and there are outliers, but on average, the more of these 5 strategies a network uses, the better is the capacity building in the hospitals involved, and we already have seen if hospitals have more capacities, they do more activities. Last question, in how far do national regional regulations for HP support the implementation of HP capacities in member hospitals? And we have just seen by Shuti how that works in Taiwan. We were looking at 5 of these possibilities, and you see for 2 we could find significant results. If networks and hospitals are acting in a political or national or regional environment where there are legal regulations for health promotion, specifically in healthcare, it makes a difference of 12%. If there are funding options, it even makes a difference of 15%. Therefore, I think the money in Taiwan is well spent doing that. But we had hoped that some other interventions which are possible have effects, but maybe they need more time. So health promotion is part of vocational training or certification concerning training. We couldn't find any significant effect here. So coming to the end, what is the summary of results? At the level of hospitals, 7 different HP capacities, and you find them all here, when institutionalized, have different but significant effects on the extent of implementation of HP strategies and activities. Effects are somewhat stronger on staff-oriented than patient-oriented and community-oriented strategies, and effects are additive. The more capacities, the more implemented strategies on average. Results concerning networks, 5 measured related to 2 strategies, have different, but significant, only 2 of them have significant effects. The more effective measures offered by networks, the more health promotion capacities are institutionalized, and only on the regional, national, environmental level, only 2 characteristics have significant effects. Therefore, it makes sense, I think, for networks to invest part of their time in lobbying with political and other actors, so that these both conditions are fulfilled. So it's worth to put part of your resources in lobbying in your environment. Well, what follows from that? What would we recommend? It is not just a belief, but there's empirical evidence now for the effectiveness of HPH capacity building to support implementation of HPH strategies, or there's a proven return on investment for HP capacity building in HPH. Therefore, it can be recommended to HPH hospitals to invest in these effective measures of HP capacity building, respectively to regional, national networks and the international network, to support capacity building by using effective direct strategies. Direct means directly oriented at hospitals, or indirect strategies oriented to changing the relevant environment. By that, HPH will better fulfill its mission to improve health gain for its stakeholders, patients, staff, community, and environment. Of course, research only could present the evidence. As you know, there are many evidence-based interventions in the world, but only part of them is implemented. To get that implemented, we need your effort. You have to take this evidence to convince your hospitals to change your networks, to change your environment, so that this can really be fulfilled to have better health gain for our patients, staff, and community. Thank you so much for your attention.
Thank you, Dr. Pelican, for your detailed and excellent analysis of HPH activities in Taiwan. We'll take one or two quick questions from the floor at this moment, if there is any, before we move on to the third and the last presentation of this session. Oh yes, here we go. Please.
My name is Clemens Hoffman. I'm from the mental health field. I spoke yesterday, and I would compliment Professor Pelican with the excellent study, very inspiring and very helpful. I assume that the hospitals that you have studied are general hospitals, and I would suggest in the future also to include mental hospitals who are frequently linked to mental health service in the community, so that also the mental health part becomes more visible.
Yes, thank you. I think that's very good advice. Of course, it depends as usual on resources. We really would like to do such a study, but you are correct. It's very important to look more specifically and especially at psychiatric care hospitals and at mental health, because in the networks there's so much going on. Thank you for your support.
Thank you. The next speaker, Yo-Juan Jack Lee, is currently the professor and dean at Taipei Medical University College of Medical Sciences and Technology. He is the chair of the Department of Dermatology at Wanfang Medical Center, and he's been very much interested in the application of information technology. And now he's going to talk about using information technology to facilitate health promotion in hospitals. Please, Dr. Lee.
Thank you, Chairman, for the introduction. Thank you for the applause. I would like to thank the organizing committee for inviting me to this talk. It's not easy to follow on the talks of the mothers and fathers of health promotion hospitals. And I always like to come to a conference on the Friday of the 13th, because what can go wrong in the conference room. Anyway, so you've heard a lot of from a lot of experts on health promotion hospital, on the strategies, on the incentives, on policies. I would like to take you to a little bit different angle to approach this health promotion activities in hospitals. This is where I'm from, Taipei Medical University. It's very close from here. And we have 3 teaching hospitals. It's all health promoting hospitals. And together there's about 3,000 beds. But my point is we actually serve 10,000 outpatients a day, okay? Not a month, not a week, not a year. We serve 10,000 outpatient mostly a day from our 3 hospitals. And this is not an exception. For most of the big hospitals in Taiwan, that's the kind of capacity that they're serving outpatients. This is where I'm from, the College of Medical Science and Technology. We do focus a lot on the how to use technology, especially information technology, to help healthcare. Okay, this is what I'm going to talk about today. So before we start to talk about why hospitals are keys, I mean, of course, because we're talking about health promoting hospitals, so of course hospitals are keys, but it's especially true in Taiwan that if we want to do health promotion, we really need to go to the hospital. These are some of the comparisons. As you can see, the Taiwan versus US, the life expectancy are about the same. Infant mortality rate about the same, a little bit better here. But when you look at the average number of outpatient visits per person per year, in Taiwan it's 15 times per person per year for outpatient visit, and in the US it's about 4. And the average length of stay in hospital is about 10 days here in Taiwan per person per year, okay? And for the US it's about 5. So we like to go to hospitals. I mean, we stay in the hospital longer. We go to hospital more than once a month. So we see our doctors all the time. And if you go to any hospital, maybe some of you have been to some of the major hospitals in Taiwan. It's one of the most, I mean, lively crowd in any indoor institution that you can probably find. Although this looks like preposterous figures compared to other countries. But as you can see, we're mostly covered. This is the rate of insurance coverage, 98% versus 83% in the US. Satisfaction is very high in Taiwan. It's 80% versus 22% in the US. And we do spend a much smaller percentage of GDP on healthcare. In Taiwan, it's about 7%. In the US, it's about 17%. So it looks like we're spending much less money for a much happier crowd. And part of the reason, I mean, it's hard to explain, but I would say part of the reason is that they go to hospital quite a lot, and the hospitals are probably doing a good job in terms of promoting health. With all this incentive system and good policy from Dr. Chu in the first presentation, you know how hard we work in the hospital to actually promote health for the patient and also for the staff. But one of the reasons that the hospitals can do such a good job is because of high information technology utilization rate. We call this health IT, or sometimes just HIT. It started quite early in Taiwan. In Taiwan, when we started the National Health Insurance System in 1995, we used 100% electronic claims, meaning that no paper can be sent to the insurance bureau to get reimbursed. All has to be electronic. So that actually spawned the whole ecology system for hospitals to do widespread computerization. In 1999, which is like 13 years ago, in the hospitals, and also in the clinics too, widespread use of CPOE is a very common thing. I mean, almost all the doctors started to use computers when they're seeing the patient. They have to enter the medication, the diagnosis, the SOAP, the chief complaint, the findings of the patient, and so on and so forth. So doctors are exposed to the computers very early, like more than 10 years ago. And in 2004, another thing happened that also bring our citizens or our patients into this HIT arena, which is the health smart card. We issue a smart card to all the patients, to all the citizens in this country. They need to bring the card to access the healthcare. So whenever they go to the clinic, they go to the hospital, they will have to bring the card. So that is actually the most commonly brought card that you will find in any citizen in Taiwan. And we started to use, to take advantage of this health information technology infrastructure since 2006. There's a routine use of real-time reminders and decision support systems. integrated into the CPOE. Because as you might imagine, if we do not have CPOE, it would be really hard to do any decision support or to remind doctors when they're seeing the patient. If they're all seeing the patient using a piece of paper or the paper chart, then it will be pretty hard for the computer to be of any help. And all the reminders or decision support afterwards will be very ineffective compared to if we have a real-time reminder. So this is the Taiwan Health Smart Card infrastructure. As you can see, that all the citizens will have a card with a smart card is a plastic card with an IC chip on it. Okay, this IC chip is encrypted, and but when you insert it into a authenticated reader, these readers are all authenticated by the DOH, by the Department of Health. You will be able to read some of the data out of this card. And actually in Taiwan, we use a dual card system, meaning that you have to have the patient card inserted into the reader and also have the doctor cards simultaneously in order to unlock the data in the patient card. So if you're a patient and you happen to get a reader from somewhere, you still cannot open the data in the card. So on the left-hand side, it's a doctor's card, doctor's smart card, and on the right-hand side, it's a citizen smart card. Of course, only healthcare professionals get this so-called health professional card. But you with that card will be able to unlock the healthcare data section and the medical data section on the patient smart card. The basic data section only contains ID numbers and date of birth and things like that. These can be read just by one card, but for all the other data you need two cards. But as you can see, major illness, injury, infant notes, prenatal examination for pregnant women, vaccination, organ donation, and also medication, diagnosis, allergies, major important order, catastrophic disease, etc. Things like that are stored on this tiny plastic cards with actually a very limited memory. But we were able to put most of the crucial data elements on this card. And whenever the patient go to a clinic, go to a doctor in a clinic or a hospital, they will have to use the card, and the doctors will be able to read all those information that's shown on the screen. In order to show you the level of computerization in our hospitals, I would like to use this model. This is called the HIMSS EMR adoption model. EMR stands for Electronic Medical Record. HIMSS is an organization that's actually doing this hospital information system society. So they provide a framework of stage 0 to stage 7. Stage 0 means that there's no electronic, there's no computer in the hospital. The computers are not used in clinical care. For stage 1, you have lab, radiology, pharmacy. Stage 2, you have this decision support system, maybe document image. Stage 3, you have PACS. PACS is also the digital radiology, clinical document. And stage 4, you have CPOE or computer physician order entry and clinical decision support system to support clinical protocols. As you can see, these are the percentage of hospitals in the US, meaning that very few hospitals are actually above stage 4. Most hospitals are still here, under stage 4. In Taiwan, we do not have the accurate number, but we are mostly around stage 3 and 4, and there is a high adoption rate, as I said. We started to use CPOE very long time ago. Well, not very long time, but about more than 10 years ago. And there's a high adoption rate of clinical decision support system because of the CPOE. Because of the CPOE, we have the chance to use health information technology, or HIT, to interact with our doctors when they're engaging with the patient. So in Taiwan, there's no hospital at stage 0, because if you are stage 0, you cannot do insurance claim. If you cannot do insurance claim, you cannot survive. because in all the hospitals in Taiwan, every one of them, at least 80% of the revenue came from the national health insurance. Okay, no matter it's private hospital or public hospital. So we have a very different system compared to some of the other countries. So even if you're a private hospital, you still rely heavily on the national health insurance for the revenue. So there's no hospital at stage 0. In the US, there's still 20% at stage 0. Okay, so I would like to, so that would be the background. I'd like to give you some example of hospital, of healthcare information technology for health promotion. As you can see, as you might have heard, the future of medicine sometimes are called 4P medicine, which stands for personalization, participation, prediction, and prevention. And these are the things, if we can actually do these things, of course, we're actually doing promotion. So we can also turn this into a 4P promotion. The health promotion should be personalized. We should engage the participation of all stakeholders. We need to be able to do some prediction so we can do prevention. And if we can prevent, we can of course promote health. So the first batch of examples are CPOE plus reminders. CPOE again stands for computer physician order entry. And the reminders is actually a form of clinical decision support. I like to use the term reminders because it's very easy to understand. But of course, behind the reminder, there's an inference engine, there's artificial intelligence, there are a lot of things going on to support a good or correct, accurate reminder. But as far as the users are concerned, the doctors, the healthcare professional, they only see the reminders though. They see the end product of the clinical decision support. So reminders are like the manifestation of the CDS. I'll show you some examples about drug-drug interaction reminder, which is quite common in Taiwan. Drug allergy reminder also almost a must in Taiwan. Actually, I believe that the DOH and the BHP, the Bureau of Health Promotion, also are pushing the allergy records, the completeness of allergy records to be put into the hospital system and as well as on the health smart card. So now we're being able to push the allergy record within the health smart card to more than 50%. It used to be very low. I mean, sometimes doctors and the patient, they just don't talk about this, but once you promote it, they become a very commonly used data field. And also drug pregnancy reminder. And also, in order to correlate with our first speaker, also reminders for cancer screening is not a big deal in most of the hospital reminders. And also not just for screening, also follow-up system of screen positive cases, because it has been known that the loss of follow-up for screen positive cases is a serious patient safety issue. So this is a screenshot for drug-drug interaction reminders. This is from one of our teaching hospital, One Farm Hospital. It says that it's a drug interaction alert, and this drug, Clarecid, which contains clarithromycin, and thawing, which contains theophylline, has an interaction, and the severity is moderate, 2 out of 3. The evidence is established, which is 5 out of 5. And the type of interaction is palpitation, arrhythmia, GI irritation, and things like that. And the suggestion is that you might want to switch clarithromycin into azithromycin or reduce theophylline by 25%. And there are a bunch of choices that you can do when there's this popping up of the drug-drug interaction. And as you can imagine, some of the drug-drug interaction reminders are appreciated by the doctors, but many are just plainly annoying. Meaning if you follow the books, there are like 14,000 DDI, drug-drug interaction, and you implement all the 14,000 DDI into your system, and your doctors will be very, very busy. Yeah. And they will probably call you and say, stop the reminders. Also drug allergy reminders. So these are when they're providing the medication, when they're putting the medication prescription, it will tell you, oh, this patient is allergic to a certain components of the drug and allergic. This is a drug pregnancy reminder, meaning if we know that the patient is pregnant, when we're issuing the prescription, the computer will actually tell us that whether this drug, what is the category of FDA approval level for pregnancy women. There's A, B, C, D, X. There are 5 levels. X means that you cannot use it. A means it's relatively safe and things like that. These are the reminders for cancer screening. This is from one of the hospitals in Jai Christian Hospital. As you can see, these are the waiting list of the patient. I mean, they're waiting outside of the clinic, and on the screen, the doctor will be able to see, when they see this means oral cancer screening, this patient is qualified for oral cancer, and this patient is qualified for colon cancer, breast cancer, cervical cancer, and oral cancer screening. So these are they label the patient even before they come in, that these patients are eligible or suitable for some of the cancer screening. And these are follow-up system for screen positive cases. So it's not just screening, not just screen them. Sometimes they come to the hospital and the doctor say, oh, you probably want to get a pap smear, and she went to get a pap smear, and then she never came back. So she will never know that her pap smear came back positive, and she might want to come back to the hospital to visit, to have further follow-up. Some other examples are also mobile phone plus reminders. These are more like patient-side reminders. So when we're talking about CPOE plus reminders, they are more clinician-side. And also we also develop patient-side reminders. Like this is an app for self-registration. So if you download this app, this is for one of our hospitals. If you download this app, you'll be able to register. You can find your doctor and then register for a number. And right before the day that you should do the visit, the system will remind you, your phone will remind you that tomorrow is your visiting day or today is your visiting day. Also, this is some other trial we've been doing, is to send a drug reminder to the patient's mobile phone. It doesn't have to be a smartphone. It can be just any mobile phone. Things like this, oh, you should take this drug and that drug. Okay, we've tried many different kind of reminders, and we were able to reduce for more than 1,000 patients that enrolled into the study. We're able to reduce the delay medication from 85% to about 18%. And the missed medication are reduced from 46 to about 5%. Meaning that if you can just send them a simple reminder, they will remember to take the drugs. So that greatly enhanced the drug adherence. That's one example for patient-side reminder. The other example is we call it Traveler's Electronic Health Summary. It's actually endorsed by a lot of organizations, Asia Pacific Medical Informatics Association, the American Medical Informatics Association, and European Federation of Medical Informatics. It's a simple system, actually. If I show you, you will probably realize that it's quite simple. There's a website that you can go to, and you can put some of the information that you want to bring with you when you travel, like medication, diagnosis, whatever, allergy, food allergy, drug allergy, and things like that. Whatever you want to bring when you're traveling. And then you can download an application, or probably you have downloaded an application, you just have to update the data. So when you travel and you found out that you lost some of the drugs and you don't actually remember the name of the drugs, you'll be able to just get it out of your phone. Or if you're in some kind of emergency situation, you might be able to show this information to the local doctors. So, yeah, I'm seeing the 1 minute sign, okay. Anyway, so the future challenges, still, there are a lot of challenges, of course, especially if we were to engage or deploy more HIT for clinicians. We need in-depth and smart reminders. Most reminders are weak and dumb, meaning they just don't care. They just tell you, oh, you need a cancer screen, you need this and you need that, without looking to the system for further information. That, for example, if a patient which has been through a surgery for colon cancer, you really don't have to remind him to do a colon cancer screening, right? So, but most of the computer system, when they're doing the reminders, they're not that smart, so they do not think that much. So a lot of reminder fatigue. If we over reminding them, we get a lot of reminder fatigue, and also. So if we want to deploy more HIT for patients, again, we talk about this 4P, and because of the limit of time, I'm unable to give you one example for each trend, but you can probably imagine in the future we'll get more personalized reminder, more participatory, meaning you can use Facebook, social network to tell your friends that you have run 4 kilometers today, or things like that, and you will get yeah. More prediction and more prevention. So that's all I have to talk about today. The thing that we use for to encourage us is from the Jonathan Wolfgang von Goethe. Knowing is not enough, we must apply, and willing is not enough, we must do. I think that also fits in the health promotion kind of paradigm. Thank you very much.
Thank you very much, Professor Lee, for your excellent presentation of current status of IT technology to facilitate health promotion. Now, this concludes all 3 speakers' presentation, and the floor is now open for discussion and comments. Please go to the closest, I think here. Please.
Good morning. Thank you for a wonderful presentation. My name is Diana from Israel. Just had a question for the last speaker. I was wondering if you have 2 questions. Firstly, a general question. You said 100% of the visits are conducted through the smart card. Does that mean in Taiwan there's no digital divide, that everybody has access to computers and everybody has the ability and the capacity to use it, or something the family can help them? And the second question, understanding that the way to access the information is when the patient and the doctor both have their cards in the system, does that require that, or does that determine that the individual doesn't see his own information unless he sees the doctor? And it doesn't mean that the doctor doesn't have access to the medical record unless the patient is with him. And of course, there's the advantage of that as far as discrete use of information, but perhaps the disadvantage that there isn't any individual access to information. So I'd be appreciated if you could comment on that. Thank you very much.
Thank you for the very important question. 2 questions about the healthcare smart cards. The first question is about the digital divide. Actually, the smart cards are not to be used, or they're not designed to be used at home. They only use the smart card during the encounter, meaning when they're in the clinic or in the hospital. So, because the smart card can only be read by authenticated readers, and all these readers are authenticated and commissioned by the DOH. There's a security chip in these readers, and only hospitals and clinics can get these readers. So patients are not supposed to be able to get a reader, so there's no digital divide issue. But of course, in all the clinics and all the hospitals, they all have the readers, and the readers are almost always connected to a computer. So there's no digital divide in terms of the healthcare provider organizations, but the patients are not to be, they're not designed to be used at home. So that also correlates to your second question. Without the reader and the doctor's card, yes, you cannot. You will not be able to read most of the medical data section, the healthcare data section, out of the card. But you can still use a common reader to read the basic section. So that's probably just it. And that's because you really want to see your doctor when you're looking at this information. Of course, maybe in the future we can open that access to a health consultant or something that some professional that not necessarily a doctor, but these people will be able to explain to the patient in a correct fashion about how to interpret the data that's stored on the card. The second part of the second question is, without the card, how can a doctor still access the information? The answer is yes, because whenever the card was inserted into a reader in a hospital, it was synced. The data will, of course, synchronize with the hospital. And actually, the card only stores a snapshot or a very abstracted information from the electronic medical record that's in the hospital. So in the hospital, the doctors were able to see much more information. The other side issue is access control, meaning if the patient is not here with the doctor, does the doctor have access to that specific patient's data? The answer is yes and no, because some hospital does have the policy to prevent doctors from retrieving any patient's data when the patient is not at your service. But it differs from hospital to hospital. But most hospitals will leave an auditing trail. So whatever you do, it's recorded and can be used later on.
Yeah, but actually, some hospitals, they allow their patient to access the hospital database at home. There's some hospitals, they offer this access. And also, now we are building a lot of clouds. Yeah, so that our patients at home, especially for those with chronic disease, they can access their results of examinations, for example.
Yes, thank you very much for the information. That's correlated to a policy for the personal health record online, because we know UK had a very unpleasant experience with personal health record online. So we are becoming more cautious about this, but we are towards the direction that patients will somehow be able to access some of the information online, provided that there is a room for interpretation of the data.
Thank you very much. My name is Dr. Kabra Boka from Nigeria. My question is a follow-up to the previous one. In a circumstance where a patient has to consult in a hospital different from the one in which is registered, either because of travel or accident, how does the system take care of that?
As I described, the health smart card can be write and read in any hospital with authenticated readers. So the patient will be able, even the two hospitals, the second hospital that the patient is visiting is not somehow in collaboration with the previous hospital. The second ones can still read from the smart card medication information, catastrophic disease history, the most used diagnosis recently, and all the flags that I mentioned. So it's quite a common practice to read the smart card before you actually start seeing the patient.
Does that answer your question? Well, for your information, I will add on. The smart card is just used as an ID card, basically. It doesn't store too much medical records. Medical records is generally in Taiwan, at least for the time being, in the hospital. So the physician will have the access. However, they will use the smart card as an ID and for billing purposes with the National Health Insurance Bureau. The ID purposes. Yeah, for the Bureau of Health Promotion. That's all. The medical records part, we are in the process of creating a cloud, a big cloud for that purpose, but it's not yet in existence. Is that correct, Mr. Stephen?
Well, but yeah, that's correct. But the card does store things like the most recent 60 medications and some key information like that, organ donation flag and things like that. So even if the patient go to a very remote place and have the card read, there's still some basic information, essential information that the doctors can. But the thing is, it's not mandatory for now. It's still like the National Health Services encourage the providers to write to the cards, but it's not mandatory that they update everything on the card. So in the previous study that we've done, about half of the cards are with information, and about the other half of the cards are not with much information. That other half will be just an ID, just like Dr. Lin said.
Okay. Any other questions? Yes, please.
Good morning. I am Eden Beltran from Philippines. Actually, I am very amazed with your presentation, considering that it is about information technology. In the Philippines, much as we would like to comply with this information technology, but most of our hospitals are not yet patronizing such. My question is these, what do you call this, attending to the medical services applicable also to the outpatients? Does it mean to say that if they are outpatients, they also have to access this card to be able to consult their physician?
Yes, the answer is yes.
Certainly.
Oh.
But if you are gonna be paid by the National Health Insurance, if you pay by cash, you don't have to go with any card.
Oh.
However, 98% of the population are covered under National Health Insurance.
Oh, it's really so amazing. How I wish we can also have it in the Philippines. Thank you so much.
And actually, if you forgot to print your card, you can still go to the hospital or clinic and get reimbursed if you can present the card, you can provide the card within 7 days to the provider. So if you really forget that day, you have to pay temporarily out of pocket. But then within 7 days, you'll be able to reclaim the money back.
So I give you advice to you. If you want to have this system, first, you have a National Health Insurance Program, Bureau, and that demands the payments will only be made if you have that particular card in place. Then you can have it. As simple as that.
Well now, thank you for this a very inspiring morning, don't you think so? We are near closure, but before we close, I would like to ask all speakers and also Dr. Chin Lon in front of the stage, because we seem to have some presents to be given out. So thank you very much for your participation. This is the end of the plenary session number 4. For those who belong to the scientific committee, I have a reminder for you. There will be lunch meeting at 12:30 in North Lounge, 3rd floor. Scientific committee members, lunch meeting 12:30 North Lounge, 3rd floor. And thank you very much, all of you.